Good afternoon, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stein. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. With me, as always, Adam Thacker, who is our Chief Operating Officer of Good Samaritan Hospital and one of our pharmacy experts, so he gets all the tough pharmacy questions as usual. We will be giving you an update this week, as always, with our local statistics, trends that we've seen over the course of the past couple weeks, which thankfully look a little more favorable. Some discussion as to where we're at as far as vaccines, what has changed with regards to recommendations as far as the booster since we were with you last. Also, kind of what's been happening globally, and then, of course, an update on testing, treatment, monoclonal antibody therapy, so forth. Leading off, we always talk about total statistics, so a little bit over 5,600 cases since the beginning, but as always, the thing we discuss most closely are those statistics that relate to the positivity rate. So all positivity rate around 6.5%, and then the unique individuals around 21. And thankfully, if we look over the course of the past few weeks, those numbers are looking better. Our county status is looking better. If we look at the statewide nature of the curve, that's looking better. So probably not slapping high fives today, but overall the trend is better.
Yeah, I think the last 3 weeks we've seen that trend to the good, so to speak. But as you mentioned, it's really important to just point out it's not linear. So we're not going to just see that that's week after week. Now we're going down to where COVID doesn't exist any longer. We're going to see some ebb and flow with that, and certainly different events and gatherings and things are of risk. When we look at the transmission rate, the 20% give or take in that area still looks at that there's a sustained transmission, and that we're seeing 20, 25 individuals out of every 100 that we're testing are still testing positive. Yep. So that's a fair amount, and knowing that the Delta variant, which makes up 98% of our positive cases, is highly transmissible. It seems to have in otherwise healthy population present with some less effects initially from an acuity standpoint, headache, sinus, allergy type of symptoms, which also make it easier to discount it as something else until it's you start to feel a little worse. Then you go get tested, and you've potentially been contagious, infectious for 3, 4, 5 days, and the number of people that you're around. So it certainly is a effect that can change pretty quickly on a dime.
Yeah, and interestingly, as we progressed along, a couple of statistics that you and I spoke about earlier is the percentage of vaccinated that we have in our community continues to rise, which is great. But then also combine that with the percentage of the population that's had the illness and has some natural immunity from that. And although we may not be at herd immunity, we continue to creep closer and closer to that.
Right. So we're seeing now Knox County, 48% of Knox County is vaccinated, and that is a percentage of Knox County residents that are eligible to be vaccinated. So we're looking at the 12 and older population that can be vaccinated. So under 12 is really taken out of that from a data standpoint, since they're not eligible yet. But we'll share some news on that, and then the natural immunity. So post infection, there certainly is an element of protection from that we have talked about. Now, it doesn't replace vaccination recommendations, but it certainly does provide some protection. And there have been, on a national landscape, there have been some very, very well-connected, smart infectious disease physicians and CDC, World Health Organization experts that have said in the United States we're probably approaching somewhere in the 85-88% of the population has had some level of protection against COVID because of how transmissible the Delta variant is. Now, when we talk about level of protection, there is controlled what we know the vaccine produces, and there is post-infection where there's a level of protection, but certainly risk of hospitalization, severe illness, death are still at a much, much higher rate than what they are with vaccine.
Yeah, and those statistics are a little bit boggy, like 60% of the time it works every time. Well, what the heck does that mean? The story basically is at least some level of protection is beneficial, whether you've had the native immunity from catching the virus, or best case scenario, which where there actually have been some good studies looking at this, contracting the illness and then being vaccinated, or being vaccinated and then contracting the illness to some degree, seems to convey the best level of immunity. And that's why we keep going back to the fact that if you haven't been vaccinated, it's still very important to. I get asked every day as to the booster. What about the booster? What should we do about the booster? Should I get the booster? And my first response is it's important to first of all get vaccinated. Right. So to our population that hasn't been vaccinated, that's still our primary goal, because again, what we have seen without question, and this is no matter what statistic you want to argue, the numbers that we have seen locally, regionally, statewide, nationwide, and worldwide is those individuals who have been the sickest, the ones who have been hospitalized in the ICU, ventilated, and so forth, have been the unvaccinated. So I think one of the continuing misunderstandings is that the vaccine keeps you from getting the illness, but as you have said from the beginning, it is something that protects you from the most severe consequences of the illness, and that is exactly what we've seen played out over the course of the past couple of months or so. Unfortunately, we went through a very dark time several weeks ago where our hospital was full, and it was full, unfortunately, with predominantly the unvaccinated, ranging from 88 up to 95, 96% of the patients that we had in the hospital or in the ICUs were unvaccinated. So my response to people, first of all, is if you haven't been vaccinated, get vaccinated. Right. Yes, the booster is out there, and we're hearing more about that. And actually, since we met the last time, the final word, which probably isn't going to be the final word, has been levied on that.
Right. Yeah, so we've gotten some clarity on boosters, and that clarity is over 65, which we anticipated is an automatic. So age-based over 65 is eligible and should, and I'm going to use should and may, should get vaccinated. And then ages 50 to 64 with underlying medical conditions, those populations we talk about every week, that monoclonal antibody treatment have been a great benefit, chronic diseases, diabetes, hypertension, obesity, hyperlipidemia, so high cholesterol, those types of conditions that make you at higher risk for severe illness should get vaccinated. Then as we drop down ages 18 to 49 who have those underlying conditions may get vaccinated. So the recommendation is you're eligible, but it's not as I guess, forceful as a, hey, you should, Yep. You're at high risk. It's kind of, in the world of risk, we talk high risk, moderate risk, mild risk. And then the fourth category is 18 to 64 that have occupational risk. So we're talking healthcare workers, frontline industry workers, grocery store workers, food services that are interacting with patrons coming in and out. Teachers are listed within that. Certainly those are occupational risk, and that hasn't been defined bullet point by bullet point to say these are the occupations. It's just more of a general occupational risk. First responders would certainly be in that as well. And so that's the clarification with the boosters of who's eligible. And then this is for Pfizer. So if you were vaccinated with Pfizer greater than 6 months ago, so probably should have led with that. It starts with the timing mechanism of if your initial series of vaccination has been at least 6 months, then you go through those categories. Moderna and Johnson & Johnson have submitted their information. They're under review. We really anticipate that in the next few weeks. And not to, for those groups, not to be looking at it like, outside looking in, like I can't get my booster, can I go get Pfizer? We're not mixing and matching right now. Some countries have done that based off of supply. We have ample supply, and certainly the efficacy from the vaccines for hospitalization, death, remains very strong. The booster is just that. It boosts that efficacy, which had waned a little bit down into the 70-80%. Now it's back up 95+%. Moderna submitted for their booster to be a half dose of what their initial dose was. In Pfizer, it's the exact same dose, same formulation. Everything's the same. And Johnson & Johnson, likewise, they submitted it will be the same dose, same amount, everything the same. And one thing that I compare it to, because we get the question, why booster? Should I get a booster? So now that the recommendations are out, the questions have started coming in, well, should I? I'm eligible, Yep. But should I? And there's some personal preference to that, but certainly those two groups of over 65, 50 to 64 with health conditions, they should get vaccinated. The two other groups, from a healthcare standpoint, occupational risk, we know the healthcare workforce has been hit hard. not from just taking care of COVID patients and the implications with that, but also contracting COVID and certainly should get vaccinated. And when we look at that over 65, we draw a lot of comparisons to influenza vaccine. Mm-hmm. We have a high dose influenza vaccine that eligibility is based off of age, over 65. So it's twice the standard dose of your typical influenza vaccine. So this is not something, while that's not a booster, it's not uncommon that you see age-based criteria being used and underlying medical condition being used, because what we know is that those individuals typically don't mount as strong as an immune response. So that's number one. And then number two, if they do come in contact with the virus, are at higher risk for severe illness.
Yeah, and that's very similar to some of the other recommendations that we have across our vaccines. As you mentioned, the age-related indications, including like pneumonia vaccine, that's changed several times over my career, but the current recommendation of 65 and then a booster after that. And similar with the shingles vaccine. We had a new shingles vaccine come out about 5 years ago or so. That vaccine is an initial and a booster on top of that. And it's all based on the fact that we know that you get a more prominent immune response with that than with the single dose. And so that's a similar thing that we're seeing with this. But in general, what our advice is don't panic about getting out right now and getting the booster, except in that population, as Adam alluded to. The immunosuppressed population, absolutely. We really feel like those folks should be the first up to bat and get boosted. Then the 65 and older with the chronic medical problems certainly next, because they're going to get a better boost out of that. And when we look at the statistics on it, really Moderna has done well with the Delta variant and the protective effects of it. Pfizer has done well also, and as we see those studies continue to march out, we'll continue to follow along and see when their boosters become available and when that gets approved also. We always want to circle back around to the early identification of illness and treatment in that population that's highest risk. We've had great success with the monoclonal antibody therapy. Our pharmacy pumped out some statistics to us last week that were tremendous, looking at all of the patients that we've administered this to, over 1,000 since this began in January with that administration. Just single-digit numbers of patients that have required hospitalization after that. And that's fantastic, because given the circumstances we were under with the hospital being full just as recently as a few weeks ago, who knows how many of those patients potentially would have required admission. So we want to really emphasize to folks that if you develop symptoms, and as Adam said, with this round, those symptoms may be as simple as nasal congestion, headache, a little bit of fatigue, low-grade fever, not as severe as what the last round was, but keeping those symptoms in mind, getting tested early to identify if you're an individual that would be a candidate for that therapy.
Yeah, and certainly we've put a lot of effort towards testing as far as making that an accessible process. So you can register online at our convenient care sites, have expanded hours to really accommodate before and after work. Our large primary care base of physicians and providers at the Medical Center of Vincennes, we're testing there. At-home testing is also widely available. And while we won't use that for diagnostic reasons such as monoclonal antibody, if you are an individual that have some mild symptoms, you don't want to go get tested at a convenient care site or through your provider, but want to pick up a at-home test kit at the pharmacy, you can certainly do your own testing first and then give you some idea of where you're at, and if symptoms worsen, then you need to be seen by a provider. But as you mentioned, treatment modality monoclonal antibody has been really a phenomenal resource in keeping patients out of the hospital, and that starts with that positive test, with identifying individuals that are at risk. Yourself and Dr. Mahan have been really pivotal in being the approvers, gatekeepers of that from a resource standpoint, and we've had great success. Now, I will add in the caveat of prevention versus treatment, and we're still really focused on vaccination as a preventative mechanism for keeping patients healthy. And when you hear some of the initial things that were coming out during this surge of, well, I can still get COVID, so why get vaccinated? Well, breakthrough infections are extremely rare, and so it does prevent actually becoming infected and sick with COVID that would lead to needing monoclonal antibody. And when we provide monoclonal antibody treatment to individuals who are sick and potentially going to worsen to hospitalization, keep in mind that there may be some of those long-lasting effects, long COVID, that still, I mean, we're probably years from knowing the full scope of what those effects may be on individuals. There just hasn't been enough time to understand that. So prevention versus treatment, medically, we always are going to shift towards prevention as the first line. Thankfully, we do have treatments such as monoclonal antibody that are working very well, but we can do better in preventing it.
Sure, and one of the things that comes up frequently, and it lends itself to that discussion that you just said, which are the potential complications or consequences of COVID, are vaccine safety and vaccine adverse events reporting. One thing that's running around rampant on the internet right now is the statistics coming off the vaccine adverse event reporting system. And I think it's important to at least discuss what that is and how that functions and what it was intended for. That system is a voluntary reporting service, whereas you as a citizen or individual who has received the vaccine voluntarily reports this to a central clearinghouse, essentially. There are some good things and bad things about that. The good things is it's a massive data collection system for anything that could be reported, as simple as local vaccine site-in reactions, fevers, chills, or even anaphylactic reactions. But it's important to realize that unfortunately that data is not something that's verified. The benefit to it, though, is if there were any strange or unusual, unexpected consequences as a result of the vaccine, it's a clearinghouse for that, so that can be identified. There are completely separate systems that are in place to more clinically evaluate those adverse events that really we believe more in terms of follow-up on what it was, what the relationship was, if it has anything to do with the vaccine. Regardless, though, what we have seen in the studies is that the likelihood of those adverse reactions is extremely, extremely rare. Probably 75,000 plus vaccines that we've administered here. Virtually no adverse events as a result of that. And yet, when we look at what the potential long-term consequences are of getting COVID, sometimes as much as 100 or more times greater risk than what the vaccine would be. And that's really what we fall back to, that's the statistic that's important.
Right, and I think it's really a key element in that when we talk about medical trials, clinical trials, that those are controlled studies where the individuals enrolled in those are being followed by a group of scientists. They are being checked for adverse reactions, side effects on a daily and sometimes even more frequent basis to capture that. But the labor of that, the resource of that is extremely burdensome. So in some of these initial vaccines, they had 20,000, 40,000 individuals enrolled in the vaccines with groups of scientists following them. What the vaccine reporting system that is publicly available through CDC is we're now north of 200 million doses given, and it gives the opportunity for anybody to report any side effect. No matter what the circumstance, and then that goes into a database and it starts to aggregate data, and if you start to see, okay, there's a number of reports for this side effect, that starts to trigger a scientific review and let's see what's going on. Important note is this wasn't created for COVID because there was a risk. This is a vaccine adverse reaction system that has been available for decades with CDC. It's become more electronic, more available now. It's on an app. If you are vaccinated at our initial Good Samaritan site and you remember sitting in the observation area, there was a TV up on the screen that scrolled through some different slides about the vaccines, and one of the slides was CDC's vaccine adverse reaction reporting system, how to use it. What was nice about it was you downloaded the app and said, I just got my vaccine, and they would, at the end of each week, send you a tickler text that said, hey, have you had any side effects? How are you feeling? And you could just input quick information to capture that. But it's not primary literature. It's not scientifically reviewed. It's just individual submission of data. So while it can be used valuably, it also can be taken out of context in the wrong direction to say that there are risks associated with that. And going back to 200 million plus doses in the United States administered, we can make a link to drinking coffee,
Sure.
to side effects of getting vaccinated, to breathing, to anything, driving a car. I mean, there are going to be untoward events that you can connect dots that really aren't dots that should be connected. And that's where we have to be careful about the internet and taking that information out of context. What we do know is with 48% of Knox County now vaccinated, the actual adverse reaction reporting of severe reactions. So we talk about anaphylaxis, where it's trouble breathing, hives, serious events that require intervention from medical team. Guillain-Barré, that is a response to where your immune system is fighting against the virus. Though it's 0.0001%. It's extremely rare. The side effect profile is actually showing to be lower than influenza vaccine and most any other vaccine actually that has been created, to the point that we've had a lot of discussion to say that mRNA technology for vaccines is probably moving its way up as the prevailing way to create all vaccines, because it can be done much quicker, much less time intensity now that they have some things figured out, and the profiles that are coming out of that from a safety and efficacy standpoint are quite tremendous, really.
Yeah, and just to simplify it, they're much cleaner vaccines. Cleaner in the fact that there are less things that your body would react to in them, and the method by which they are synthesized is basically much more targeted than what previous vaccines would be. So, yeah, we've discussed a bit in our previous programs over the course of the past year or so that this is likely going to be the technology that most of the newer vaccines are developed under, because of those statistics that we're talking about. So just be very cautious. Obviously, there's lots of good and bad information that's out there, but drawing causation type relationships off of that type of data is very poor. No different than as the sun is going to come up every day, the rooster crows. It's not the rooster's crow that causes the sun to come up. That's not a causation-based thing. So similar to what these studies are and reporting systems, we want to look at what the blinded studies are that are followed up, where we can actually develop some decent data off of that. And so far, that looks fantastic, along with what we've seen our local data to be.
The same would be quite true with the ivermectin discussions, in that there were reports of ivermectin being used and patients getting better. And I'm quite certain that happened. But the causality of those two things, once put under the scrutiny of actual controlled randomized studies, which is what we use in the medical world, showed that causality wasn't ivermectin antiviral cured COVID. It was truly coincidental, and some unfortunate assumptions were made that then led to individuals that did have ivermectin overdoses toxicity. So that's the risk.
As Adam had said, testing readily available. The testing that's available in the local pharmacies, exactly the same type of testing as far as antigen testing that we are using also. Biggest criteria with that is that the test is performed in an accurate manner. It's not the accuracy of the test that is ever in question, it's that it's done properly. So making sure that you follow those guidelines with regards to that. But getting in to be tested, getting in to be evaluated, very easy, either with community care, primary care. We still are encouraging people to try to avoid the ER at this point in time, because hospitals still very busy, and we want people that can be evaluated in the ambulatory setting and then set up to be further treated as necessary as quickly as possible, which is the most effective manner to do that now. As we move over the course of the next month or so, we expect traditional viral stuff to be coming up. Obviously, influenza vaccine, it's season for that again. We've got opportunities for people to get vaccinated in a whole host of manners right now.
Right. So coming October 13th, 16th, and 18th, and we'll be sure to put this information out through our social media posts and various communication avenues. But those are our community flu drives. We'll be offering over at the large parking lot next to MCV this year to add some additional space and kind of stay out of congestion of the parking lot here at Good Samaritan, and make sure that we're staying away from the emergency department access and flow. But those dates will be where we're opening that up to our community. We have a mass vaccination drive on the 14th for our employees here at Good Samaritan, and then certainly through local pharmacies, the health department, there are avenues to get vaccinated as well. influenza vaccine, we have it in stock. I know some we're already offering that to inpatients. So when patients are admitted, we automatically look at have they had their annual influenza vaccine and offer it at that time. So we've already started that process. And now in October, we will start looking at offering that to the community, and really provides protection. We recommend October, November getting vaccinated, and provides influenza protection really through March, which is the typical season.
As Adam said earlier, those vaccines are dose based on the higher dose for the older population over 65 and regular dose for all the rest of us. And that goes all the way down to the range of 6 months for kids. So we vaccinate children down to 6 months with flu vaccine, and they get a half dose initially and then a repeat dose within a month or so. So as of, if we go back to the last swine flu epidemic that we had, that was really when that got changed to vaccinating our higher risk patients to vaccinating everybody. And that was simply because we saw such a broad spectrum of disease across the entire age population, not just in the higher risk group. So that's really when that changed now to be the standard of care to vaccinate everybody from that 6 month up range.
Yeah, which also brings in the conversation from a COVID vaccine standpoint is we're looking at eligibility as 12 and older at this point. So that 5 to 11 group that we've talked about, that officially has been submitted now by Pfizer. They're anticipating 4 to 6 weeks, so we're looking at end of October, early November as the time frame that ages 5 to 11 are expected to be approved under that emergency use authorization. It'll go through the same review that we talk about all the time with these updates to vaccines, that CDC will review it, make recommendations for best immunization practices, reviewing the data. FDA will also do an independent review and then go from there. And then that next group is 2 to 5 and then under 2 because dosing does change. And also when we look at 5 to 11, because I've had the question, why did we stop at 5? We're talking school age, elementary, and that covers the continuum of really kindergarten on up, where they're out of the house, more mobile, congregating in school settings and such. So that's the focus on that end of the vaccination spectrum right now.
Yeah, one of the other questions that comes up not infrequently is pregnancy and breastfeeding. And without question, all of the experts, maternal-fetal medicine, OBGYN, all of those that are providers have recommended vaccination of our pregnant population and breastfeeding population. And it's simply because that population in itself is higher risk, not just because of their immune systems, but mechanically some of the things that change associated with pregnancy. So it's important to realize that that population, although they're a little fearful of anything during pregnancy, is definitely an indication, and we're encouraging that. We've had to utilize monoclonal antibody for a couple of patients over the course of the past few weeks or so because of concerns of more severe illness, because we don't want that illness to have consequences on the pregnancy either. So not just in the pediatric population, as Adam's alluding to, but right now we are vaccinating our pregnant population also.
Yeah, and it comes back to that risk benefit that we talk about, and infection versus vaccination, and certainly when you look at those organizations that have promoted that vaccines are recommended for pregnant women of childbearing age, breastfeeding women, the risk of a COVID infection, the numbers are staggering based off of the risk of that population for hospitalization, for death, for early miscarriage. So not just risk to themselves, but risk to their unborn baby as well. And really the data is what those expert groups are going off of. And that's where we look at it and say, pre-pandemic, the medical community was very much reviewed, not 100%, but very much looked to for medical recommendations. These are experts with decades of training, decades of experience, hundreds of thousands to millions of patient examples to say, this is the best practice, this is what we should do, this is the safest, most efficacious in whatever the discussion was. And the pandemic has brought about, internet and social media and opinions that have just transmitted wildly for one reason or another, but really need to get back to the medical experts are the experts, and they are putting forth the recommendations that are in the best interest for the safety of everyone. And it's not one group is saying pregnant women should get vaccinated, another group is saying, well, maybe not. I mean, those ACOG who are obstetric gynecological, the maternal fetal medicine. Those are the two big groups, and they have jointly said absolutely the risk of infection compared to any mild risk of vaccination, one outweighs the other tremendously.
Yeah, absolutely. And Adam has scratched the surface of what we all deal with on a daily basis, and that is that who are the experts when we look, and the experts are the same people that were experts 2 years ago and 5 years ago. It's the people that clinically take care of patients, who are clinical pharmacists, people who actually deal with the side of medicine, and not necessarily politics or anything that mixes poorly with medicine. So we ask people just to be very critical of what your sources are and who your experts are, because just because you shout the loudest or you sound the best at the school board meeting in no way makes you an expert. It's something that we try to rely on people that clinically have the most experience with patients to make the best recommendations off the best data that we have. Any other things we need to touch on before moving to the phones?
I don't believe so.
Mallory?
We got a few today.
Okay.
All right. If you were vaccinated, then you got COVID and had the infusion. Should you get the booster, and if so, how long should you wait?
Sure. So this is a great and common question that comes up, and it also pertains a little bit to the topic of if that circumstance happens and my workplace requires me to get vaccinated, what do I do about that? Because we would prefer a 90-day waiting period from the time that you receive the monoclonal antibody, because essentially this monoclonal antibody is helping to assist your body in fighting off the COVID virus. And so while it's doing that, your body is not going to have as strong of a reaction to build its own antibodies for the virus itself. So generally 90 days is that time span that we want to look at for that, as far as having the illness, receiving the monoclonal antibody infusion, and then waiting 90 days to get either the vaccine or the booster. That being said, there are some folks that are having a difficult time with regards to their workplaces, because they need to get vaccinated as far as their work is concerned to reduce their risk, but we still want that 90-day waiting period. And that's not an exemption. That's a, hey, this is the smart thing to do medically. Again, the right thing to do from a medical standpoint.
Right. And that's what we're doing here from our employee standpoint, is we're viewing that as a medical deferment rather than an exemption. And that 90-day, I mean, that is sticking to what we've always said. We're going to follow the science and the recommendations for the best efficacy of the prevention with these vaccines, and that is that 90-day period. So just kind of for both parties, vaccination, infection, yes, should get booster regardless of monoclonal antibody. If you've had monoclonal antibody, there's a 90-day waiting period, but anybody who's fully vaccinated post 6 months, even if they've had infection, they should still get the booster.
Yep.
Okay. When can you get the flu vaccine after the antibody treatment?
Sure. So different situation, and thankfully because it is a monoclonal targeted antibody, you can get it any time. There's not a crossover in the fact that your body is not going to form that immune response. What we're really looking at is the monoclonal antibody targeted at COVID is helping your body's immune system, so your body's immune system is not necessarily going to be ready for the vaccine, but as far as the flu vaccine is concerned, any time afterwards is fine.
And because it's probably on there as a question, flu vaccine and COVID vaccine can be given at the same time together, different arms, but there is no waiting period between one vaccine to the next. And actually there's more and more recommendations that getting them at the same time mounts an immune response. And the other question that comes along with that is, will the side effects be worse? Will it make me feel worse? In looking at history of vaccines, getting multiple vaccines at the same time has not led to someone feeling worse than if they were to spread them out multiple days.
Okay, kind of along the same question, but this person just had their booster. How long should they wait to get the shingles vaccine?
So same, there is no, so COVID vaccine and any other vaccines, there is no recommendation of a waiting period. I think, as we've talked about over the last 18 months, the number of changes through all of the COVID recommendations, it can make your head spin, and then you mix that in with the opinions, it definitely can make your head spin. When the COVID vaccines first came out, the recommendation was no other vaccines to be given within 14 days of the COVID vaccine. It was not out of a patient safety concern or side effect profile concern. It was a research and data tracking element, so that if there were side effects that hadn't been identified in the 40,000 plus people in the trials, now that it was pushing out to millions, that they knew, okay, that's the COVID vaccine, rather than, oh, you got 3 vaccines on the same day, now what caused what? Once the side effect safety profile proved to be, as great as it has been, that cautionary step of a 14-day waiting period was removed, so there's no longer a waiting period.
It's certainly, you may run into a bit of that wives' tale or superstition type of thing. If somebody at the pharmacy or otherwise tells you, hey, we'd really prefer to wait a couple weeks, there's certainly nothing wrong with that,
Right.
but there's also not a medical indication to do that. They can be administered together.
Okay, when do you foresee vaccine availability for 6-month and older children?
I think it's going to be a while. I haven't actually seen any predictions of time. I can tell you that clinical trials are going on now for 6 months of age and older. Looking at that up to 5 group. I would anticipate it will be next year sometime. Probably more like this time next year, not January. It's a different dose. When we look at the 12 to 16 population, we're talking young adults from the way that they respond to medication.
Yep.
When we look at the 5 to 11 population, their immune systems and development of their bodies is similar to that of that 12, 13 preteen group in the fact that how they handle the vaccine and their body responds is similar. Once you start getting below 5, it's a different mechanism, because now toddler, infants, developmental days are different, and so there's a different methodology for looking at how the vaccine will be administered. Studies are ran differently. I would anticipate that it will be next summer or later, but I haven't seen any projections yet.
Yeah, that age range is just much more complicated. There are obviously a whole host of our childhood vaccines that are going on around the same time. So it's complicated not just because of metabolically, as you alluded to, and developmentally, but it's also complicated by, there's a lot of other things going on at that time as well.
Now, on the front end of that 6-month group, obviously if you have a 6-month-old, this is not the case, but if you are pregnant, getting vaccinated, there is data that shows that the antibodies produced from the COVID vaccine to pregnant mother pass through to your baby and provide protection upon birth.
Yes.
Okay. Are those hospitalized patients who were vaccinated somewhere other than Good Samaritan counted as unvaccinated?
No. Vaccine status is validated through first and foremost, patient information. So patients are asked upon admission, or their family is, depending on their ability to answer. And then we look at what are called the immunization databases. If they are an Indiana resident, we can look at that and see if they have a documented vaccine. The location of where they were vaccinated is not relevant to the vaccine status. We get that information otherwise.
Okay. Someone is asking about the difference between the vaccines, the first, second, and third. I don't know if you can explain, like, if they're different from each other, same amount, same vaccine, just 3 times, or
Sure.
how that works?
Pfizer vaccine that the booster is approved, all 3 doses, dose 1, dose 2 to be fully vaccinated, dose 3 that is the booster are the exact same dose, exact same formulation. Moderna has submitted for their 3rd dose to be half that amount. So dose 1, dose 2, 100 micrograms each. Dose 3 would be 50 micrograms, exact same formulation. Johnson & Johnson will be the exact same formulation. I know there's been information put out there about reformulating for other variants, but what we have seen is that the protection provided hasn't really dictated that. If there are other variants that emerge that have vaccine evasive principles, that will be another step that someday we'll talk about on here. I hope that we don't, but we may talk about it on here someday about a reformulated vaccine due to emerging variants.
Yeah, and another question that kind of goes along or piggybacks with this is a bottle of Pfizer vaccine, bottle of Comirnaty vaccine, same.
Yes.
Bottle of Moderna vaccine, bottle of Spikevax, same vaccine. So all of this basically just has to do with the authorization, FDA authorization, with regards to the drug, the chemical that was in the vaccine, and then naming it at that point in time. which in my mind, Spikevax wins over Comirnaty every day.
All day.
So bully to you, Moderna research folks, for having a better marketing team.
Okay, this is kind of a two-part. Can you give an update to the percentage of vaccinated employees here at Good Samaritan, and what is our plan for the future with the unvaccinated employees?
So we are at 67% of our employees at Good Samaritan have now received at least their first dose of Pfizer. If they received Johnson & Johnson, and they're in that group as well, or Moderna. We administered Pfizer here, which most have received it through the hospital. But 67%, which has been steadily moving up pretty significantly. I believe just last week I reported it was around 60, so about a 10% increase. Our mandate from a employment standpoint is still that November 1st is when we'll know kind of that true number of who's vaccinated and who is not. And per the president's plan for path out of the pandemic, any unvaccinated healthcare workers will have to submit to testing, what's called surveillance testing on a weekly basis, to ensure that we're identifying cases early for COVID. Details of that are still yet to emerge from the presidential plan, and we'll adopt those as they do.
Okay. I was vaccinated while pregnant and breastfed while having COVID. Can my child be tested for antibodies?
Technically, yes. The important thing, and this really brings up a better topic, which is what is the utility of antibody testing? So the question was, pregnant individual delivers, as Adam alluded to, we know that crosses the placental barrier. Those antibodies get passed on, no different than with breastfeeding. That child bears the benefits of that despite not being vaccinated. But is there some utility in testing for antibodies? And the answer clinically is no. There is no value in that. Now, there are a whole host of folks that will ask me on a daily basis, well, should I have my antibodies tested? It doesn't really change anything that we do. The numbers that we quote to you, the statistics that we talk about, the protective effects are based on huge studies that tell us what those numbers are. They don't so much pertain to one individual and what their response is, but it helps us to know how to handle that as it pertains to population health. So really, there's not much utility. Now, there are a couple of schools within our system here that have an out for people that if they get antibody testing, that they don't have to quarantine during that period. But from a clinical standpoint, there is no CDC recommendation for such. There is certainly nothing coming out of us from a clinical standpoint that antibody testing is of any benefit. Really, if anything else, it is a point of interest, if nothing else. I know one of the things that you and I both did is prior to our vaccinations back in December, we both got antibody tested mostly to see if we had been infected and been one of the 43% that didn't have symptoms, and I was negative, and I think you were as well. So the bottom line is basically it's somewhat of a novelty to know that data, but it does not change anything that you would do as far as an exposure, a quarantine, whether to get vaccinated or not. It's just something that really we talk about qualitative and quantitative. We don't get a level of 300 or 500 or 200 that says that's good or adequate. That's not a measure within the antibody testing. Right.
Okay. Can you explain why ivermectin is a bad thing to take?
It's not a bad thing to take for the appropriate reasons. And as Adam alluded to, thankfully it went through all the same process to become an approved drug back when it came out decades ago. And we still use it, and we use cousin drugs to it for treating parasitic infections. Where this came from, unfortunately, was a whole host of let's try it and see what happens. And the let's try it and see what happen approach suffers from a whole host of problems, not the least of which, as Adam talked about, was when we see all the people that get COVID, there is a certain percentage of folks that are going to have no symptoms whatsoever, 40, 50%, maybe a little more, maybe a little less. And there's a certain percentage of people that are going to get the illness and not bear the consequences as a result of a more severe infection. So when you throw a medication at something and it's not necessarily studied, there's always going to be what would be a perceived causation of benefit. And in a lot of places, specifically a lot of the early data came out of South America, and it was, hey, let's try this because we have this drug laying around and readily available, and we think that it has some antiviral properties, and unfortunately was not studied appropriately. Now, honestly, we all wish that early on, starting a year and a half ago, there were some blinded, controlled studies that were performed in that manner, because right now, we would have the answer to the question which so many people are asking right now, which is there truly a benefit or not? There are studies that are going on right now, but unfortunately, they didn't get started a year and a half ago when they would have been the greatest benefit. So using that medication for the appropriate purposes is very effective, and it's really a one dose and done for the majority of the parasitic type infections that we use to treat it with. The problem is it's not studied in any manner to show any benefit, and regardless of who you talk to, whether you believe the CDC, whether you believe an infectious disease expert, none of those individuals, none of them that practice clinical medicine are recommending that as a therapy right now.
Right, and it goes back to here in the United States, our sources of truth are the FDA and the CDC for how to treat illness and medications. And the studies that they have done do not validate using ivermectin. And I think the point that you mentioned with parasitic treatment is you're looking at a one-time dose and done. Keep in mind that even if those antiviral properties of ivermectin were to have some benefit, although it's been shown that that benefit has not been worth the risk, you would have to take that daily. And so these are not benign agents. This is not drinking a glass of water. This is taking a drug, a medication that is in your body. And if we don't need to do that, then we really shouldn't be taking that. And the stat that just kind of blows my mind is that in July and August, the poison control centers. So across the United States, we have poison control centers where people call it 24/7, 365 for any poison to get guidance on what has happened. A child got into household cleaning agents and drank them, or somebody's overdosed on a medication. They went up 245% based off of social media and internet recommendations of taking an anti-parasitic approved agent or a veterinary agent, whichever way you want to go with it. So the risk is not benign in that, and that's the most important thing, is its safety and efficacy. Efficacy was doubtful to mediocre, well, not even mediocre, was doubtful, and the safety profile was certainly risk associated. So when you go back over the last number of months since the pandemic started, we've talked about chlorine, those types of aquamarine agents. We've talked about UV light ingestion. We've talked about ivermectin. We've talked about, and to even just call another drug in there, right out of the gate, there was discussion of Zithromax, a very well-known antibiotic. We use it all the time. It's very safe, but it has mild antiviral properties, and so it was used early on when we just weren't sure what to use, and we were kind of grasping at straws to treat the patients coming into the hospital. And very similarly, it showed that it really wasn't of benefit to be used. So we've kind of went through this on many different stages throughout the pandemic, and it's just not a safe approved agent to use. And even if there were some safety, it would have to be taken every day. So the benefit of that versus one shot, 21 days, another shot, I'm protected, just seems to make all the sense in the world. That we'll continue to focus on FDA approved prevention methods.
Yep.
Okay. This person said, would I need to get the first COVID vaccine again? It has been 4 months since she got the first one.
There is no resetting of the series. So if you received shot 1 and for whatever reason have been delayed in shot 2, that 21 days is they're at least 21 days apart. And the recommendation is that they are 21 days so the immune response mounts on one another. But there is no time frame that you reset and have to get 2 again. You get the second shot, your body's immune system will recognize that and build upon it.
Wow, marathon one today. Fantastic. Great questions, everybody. We appreciate those. And we'll be back with you again in a week. Please be safe.